Good day and welcome to another of the Genoa Underwriting Managers CPD series. I'm Michael John Demand and I was one of the founders of the company. Genoa, as many of you'll know, is a liability insurer with a long history in the professional indemnity space. We're not a typical insurer in that we don't insure your car or your house, and instead we are specifically focused on insuring professionals like yourselves. The Genoa team has been offering professional indemnity solutions for many years, and we are regarded as experts in this space. I have the pleasure of introducing Dr. Brad Byra, who'll be focusing on medication errors. Over to you, Brad.
Hello, everyone, and welcome to today's session. It truly is a pleasure to be here with you, and we're going to be talking largely over the next 15 minutes about medication errors. I think as a disclosure, it's fair to say that we're not going to be talking about which medication, which prescription, or which preparation to be describing or dispensing for which condition. What we are going to be talking about is healthcare and medication safety, and looking potentially at some tools and techniques that you could use that are best practices through the World Health Organization and other support providers to give you the best mechanisms for limiting the risk that medication and prescribing and dispensing has on your practice. So to start off with, we talk about moral hazards. I'm not sure how many of you know what a moral hazard is, but let's take a moral hazard as being the unintended, unfortunate outcome of a good intention. And an example of this that happened in my world very early on in the mid-1990s was when we started looking at HIV and AIDS, and we started looking at how to provide financial support for persons who became HIV positive at a time where the move with CD4 counts, when you reach 400 in your CD4 count, down to 100, down to your unfortunate demise, was very, very short. So what we did is we put in a mechanism that if a person became HIV positive and had purchased a certain insurance, that insurance would sound and money would be paid to that individual for their end-of-life care and their funerals. Sadly, what happened is people saw the value of that money in their economically stressed circumstances and end up seeking to become HIV positive to get the payout. That's an example of a moral hazard where a good intention has an unforeseen consequence. And broadly, healthcare is the same. If we look at medication safety and polypharmacy, a report written by the World Health Organization and published late in 2019, they state that healthcare interventions are intended to benefit patients, but they do also cause harm, and we know that to be true. That complex combination of the processes that we use for diagnosis, the technologies we embrace, and the human interactions between ourselves as practitioners, patients, and other both healthcare and social participants is what makes up our healthcare system, and it does bring significant benefits, but it also brings inevitable risk to the patient. And sometimes that risk to the patient results in actual harm to the patient. And that's where we talk about the moral hazard of healthcare, is that while our best intentions are to only do good, sometimes an adverse outcome results. And when an adverse outcome results, it can either cause a morbidity or mortality impact. In other words, it can make somebody worse, and in the worst instances can lead to their premature demise. We know in terms of the studies in medication safety in high-risk situations that adverse events in healthcare are now the 14th leading cause of morbidity and mortality. That puts it in the same league as tuberculosis and malaria. And in this country, where HIV, tuberculosis, and malaria are the three biggest areas to focus on in terms of preventative long-term risk, adverse outcomes and patient safety outcomes falls into that same category. So the most important thing when we look at patient safety, and we know that 1 in 24 patient engagements can potentially result in harm. So how do we prevent particularly avoidable harm, not only in the patients during our care, but not only the patients and their family, but the patients and the family and their broader environment? And so in addressing that, we are looking at the global patient safety challenges that the WHO has put together, specifically, and in terms of the context of today's presentation on medication errors, we're looking at the strategies of medication without harm. Now, medication without harm is a broad tool, and I'm going to use the WHO wheel and their key action areas to give you a sense on how this would relate to your practice. So within the context of medication without harm, we're talking about your care that you provide your patients, regardless of whether it's a public or private setting. I think the issue around safe prescribing, safe dispensing, safe administration, and the mechanisms of safe medication strategies follows this very well-described wheel. There's 4 components to it that you might want to know. The first is the component relating to the patients and their public, and you can see there the involvement of patient organizations and patient advocacy groups, reporting by patients and patient engagement are very important, because how do we know as individual practitioners or groups of practitioners or components of a healthcare system if a patient is doing well or poorly as a result of their medications if we don't get feedback from them and engagement with them? Equally with that, there's the component, and you'll see it on the top of the purple slice almost to 11 to 12 o'clock, is the issue of public awareness and medication literacy. We may assume as practitioners that our patients understand the side effects, the implications, the physical and physiological and psychological impacts that any psychoactive substance may have, or physiologically active substance may have. But the patient or their family may not be aware of it in the same way that we are. So that becomes key when we start looking at mechanisms within our practice to support the patient and the patient's family in terms of their medication literacy and encourage their feedback and encourage their support. So that's the first component of medication without harm. The second component looks at us as professionals, our education and training, how well we communicate and what kind of teamwork we bring to play. Now, for those of you that like to read, at this point, I generally suggest that you get a copy of a book by an author called Atul Gawande. And Atul Gawande is a general surgeon who did a lot of work with the World Health Organization on looking at poor outcomes in surgical situations. He wrote a book called the Checklist Manifesto. What the Checklist Manifesto contained within it was the realization that as healthcare practitioners, not dissimilar to other professions, we sometimes leave things out. When we leave things out, either by commission, we've left it out on purpose, or we've left it out by omission. In other words, we've left it out as an error, as opposed to an action that we've taken, the commission. It can lead to an unfortunate outcome. Now, that poor outcome could be a negligent outcome, or it could lead to a complication that was preventable. And in Atul Gawande's book, he speaks about having a checklist to say, have we gone through these 3 or 4 or 5 necessary steps to ensure that all the procedures or processes or practices are followed? So he wrote that book called the Checklist Manifesto. He then wrote a second book, and that book he called Better, which looked again at quality improvements in healthcare and how we can improve our capacity and our capabilities at points of care. He then wrote a third book called Complications, where he reflected on the fact that even though we know as healthcare practitioners and professionals what we should be doing, we don't always do it. So our incident reporting and our learning, linked to our capacity at point of care, linked to our communication and teamwork, linked to our education and training, is a key part of how we address medication errors. So later on in this presentation, I'm going to share with you 5 steps. I'm also going to share with you some key ideas. And a self-reflection at this point in this program is for you to ask yourself, do I have a checklist for providing medication to patients? And if you do, what is on your checklist? And you might want to take a moment to write them down, because I'm going to take you through 1 or 2 best practice medication checklists a little later on. And you can compare what you have to what is considered to be global best practice in medication prescribing, dispensing, and administration. The third component of the medication without harm wheel is the issue of medicines. And here we look at 4 things. We're looking at the quality and safety of the product. We're looking at the naming, labeling, and packaging, the logistics, storing, and disposal, and the right product at point of care. Now, in our case, as practitioners, You may be a prescribing practitioner, you may not be. That doesn't matter in the sense that if you're treating a patient who has received medicine from a prescribing practitioner and you're not prescribing, doesn't mean you don't need to know what products that patient is taking, what the naming and labeling of that is, and whether it is the right product at the right point of care. Equally, if you are a dispensing practitioner, your storage, your disposal, the logistics around keeping stock, in addition to your right product at right of care, becomes important. And you may need to be having a protocol specific for the receipt, storage, and disposal, as well as the dispensing of your medicines. Again, the question I would ask you at this point is, do you? If you do, that's great. And if you don't, that's something worth looking at. And then the final piece is the systems and practices of medication. I'm going to read these from the top left down to the bottom right, because in sequence, it's what leadership and governance do we put in our system and practice of medication management within our practice and within our colleagues. Then the second question is, how do we prescribe, prepare, and dispense medications in our rooms, or request that post-prescribing, the preparation and dispensing is done in a manner that's safest for the patient. With that, we then say administration and patient monitoring, and monitoring and evaluation are two key points. So at this point, again, a question for self-reflection and to go into for our later discussion is, number one, is, are you monitoring your patient? And if so, how are you monitoring your patient? And how frequently are you monitoring your patient after you've seen them in your rooms? You've seen them in the rooms, you've reached a diagnostic opinion, you've issued a prescription, and we're going to talk about that in terms of the Health Professions Council requirements and issuing prescriptions. Then the patient leaves. How are you following up with that patient to make sure that the care that they're giving and the outputs or the outcome of that medication meet both therapeutic expectations and their therapeutic needs? So that collectively is the medication without harm wheel. And within that, there are three action areas: the polypharmacy, the transitions of care, and the high risk situation. And I'm going to spend the next couple of minutes going through those three as we then unpack this a little bit further. So pharmacovigilance is a broad statement. And pharmacovigilance in this case looks at a couple of key things. We look at how you improve patient care and safety in relation to the use of medicine and all medical and paramedical interventions adjacent and ancillary to that. We also look in pharmacovigilance at the improved public health and safety in relation to the use of medicines, because regardless of whether your practice is in a private or a public facility, you're still influencing public health because your patients are members of the public. They interact broadly with other members of the public. Further, pharmacovigilance looks at detecting problems relating to the use of medicines and communicating these findings in a timely manner. There's currently a range of studies that are being done in order to assess the side effects or contraindications of a medicine or a treatment by looking at the adjunctive prescriptions that are given to manage poor medication outcomes. So what a lot of pharmaceutical interventions are now doing is they're saying, based on the frequency of a second or third line prescribed medicine, they can anticipate whether the first line diagnosis or the first line treatment was effective or not. That then contributes to the assessment of the benefit or harm or effectiveness and risk of medicines. And that allows us to put prevention of harm and maximization of benefit education programs into place. Pharmacovigilance, in addition, encourages the safe, rational, and more effective use of medicines, and it promotes understanding and education and clinical training and its effective communication. So I say this, and you can read this on the screen. One of the startling things for me is we do this across the SADC regions and provide this training to multiple audiences in multiple countries. And so doing this in Botswana recently, one of the pharmacists and some of the clinicians put up their hand and said, "Oh, yeah, we understand this absolutely. This is the paracetamol cure." So I said, "Well, what do you mean by that?" They said, "Well, if you've fallen off a ladder, you get paracetamol. If you have a headache, you get paracetamol. If you've got a fever, you get paracetamol." I said, "Well, explain that to me." They said, "Well, our formulary in the rural areas only has paracetamol. So sometimes when we start looking at improving public health and safety in relation to the use of medicines, we also have to be cognizant of what medicines are available. And I use that a little bit tongue in cheek, but we often get into the habit of using a very narrow range of medicines within and sometimes adjacent to and sometimes outside of their therapeutic bands or their common usages. So there are key elements in medication use that you should be aware of. And as we go through this slide, I'm going to refer you to the Health Professions Council's ethical guidelines. You should be able to download these guidelines. You can download it as a single PDF booklet of 334 odd pages. And within that, all of the booklets are contained in that download. So in terms of medication use, you need to be mindful and record patient information. And this needs to be done in addition to the patient education you give, in addition to the diagnostic information that you manage. So confidentiality, disclosure, patient record keeping is key here. And I would refer you to booklet 9 of the Health Professions Council Ethical Guidelines. The drug information that you share would fall under protecting and providing information to patients, and that's under booklet 5. The adequate communication strategies are what you need to use, and WHO and other pharmaceutical safety and medication safety strategies use SBAR. What situation are you using? What background, what assessment, and what recommendations have you used in order to decide which medicine to use, which manner to use it? Then in terms of medication use, you also have to be mindful of the drug packaging, labeling, and nomenclature. If there's any drug device acquisition, use, and monitoring that needs to happen, you need to consider the environmental factors. And those environmental factors are the situation of your patient, your ethical conduct, your responsibilities as a practitioner, which are all held in booklets 1 and 2 of the ethical guidelines of the HPCSA. You also have to consider in your practice, do you have other staff who may or may not be involved with the patient education or patient support? And if so, have you educated your staff properly, and have they demonstrated not only competence, in other words, a knowledge of the information, but the competency in how they apply that information? You may also need to consider patient education, and here you need to look at informed consent. And that's booklet 4 of the HPCSA guidelines. Why is patient education important? Because when you make a recommendation to a patient based on what you determine their needs to be, it's the patient's decision whether they adopt that or not. And they can't make that informed decision or well-considered decision unless you've shared with them as much information as possible. That falls into your quality processes and your risk management strategy as it relates to medication use. So there's a lot to take in here, and we're going through it fairly quickly. But what I do suggest that you do is download the booklets, have a look at the ethical guideline booklets in relation not only to medication use, but also in relation to your standard practice on a day-by-day basis. So when we start talking about the administration of medication, they are what are known as the 5 rights. Now, had I asked you this before putting it on the screen, I would say to you, what are the 5 rights? And you should have been able to say, we want the right patient to get the right medication in the right dosage through the right route at the right time. Now, it's true in hospitals, but it's equally true when you prescribe medicines for a patient to take at home, because you may have different medications of different dosages, some oral, some that may be aerosol, some that may be injectables, and they need to happen at the correct times of day. Now, we've had examples where working as a risk manager in a hospital, the patient post-surgery was given a bag full of Clexane injections with instructions on when to administer them. The question that we would ask from a risk management perspective is, how do we know that the patient is using them in the right way at the right time? And so there we would look at medication administration records. And I would ask you at this point, do you keep a template record that you give to a patient so that they can record what they're taking, in what dose, in which route, at which time of day? And I recall being a foster parent to a young child. He was probably 6 years old at the time, and he was HIV positive. And one of the agreements when he came home and spent the weekends is he had a medication administration record that I had to sign at each time that he needed to take which medicines, so that when he went home, he could demonstrate that I'd been compliant with him on the use of his right medication in its right dose, with its right route, at its right time. Now, when I spoke to you earlier about the risk management strategies that you may or may not have in your practice, and we spoke about the medication without harm wheel and the strategy, the mechanism that you support your patient for them to be reminded on how to take their own medicines, if indeed they are, sits with the burden of responsibility on yourself to do. So the question for you is, do you have a medication administration record? Do you keep one? Do you give your patients one? And do you follow up with them that they are keeping them and using them in the right way? Because medication compliance is always a challenge. There are many medication challenges across our landscape. Some of them relate to access to substandard or counterfeit medicines. Donated medicines are often a challenge because they may or may not be medicines that are needed or directly needed. They may or may not be expired. They may or may not be sourced from the same source as other medicines. We're not going to talk about any of that in today's conversation. We are going to talk a little bit now about polypharmacy and the use of 4+ medicines and the risks that that inherently has. We're also going to talk a little bit about the incorrect use of medicines and the risks that that brings. Suffice to say that interactivity between medication and medicinal preparations both plays a role in polypharmacy and in the incorrect use of medicines. And then all that I'm going to say about the informal distribution channels is we all know, not that any of you would do it in your practices or in your life outside of your practice, but we all know of people who say, well, I had a headache or I'm feeling a bit stressed, and somebody at work said, well, just take 2 or 3 of these. And they share medicines from their own, I'm going to call it loosely, their own dispensary, their own stash in their handbag or their drawer or their briefcase, that you've got patients coming in taking medicines. And we say, well, where did you get this medicine? And they say, oh, a colleague gave it to me, or a friend gave it to me, or a coworker gave it to me. Those are informal distribution channels. Outside of those, where people are buying medicines, which could be counterfeit or substandard, or prescription medicines for a single use or an individual's use that are then shared with other people. So the challenge that you have there is you don't know when a patient comes in whether they are making use of an informal distribution channel for benzodiazepines or for painkillers or for any other form of medicines that they may or may not disclose to you. So let's just pause for a moment and have a look at polypharmacy and understand what those risks might look like. So conventionally, polypharmacy is the overuse of medicines, but it may be more useful going forward to talk about polypharmacy in terms of the appropriate use of medicines with each other. Because there are some medicines, to use an example, where a diuretic is diabeticogenic. And so one practitioner is prescribing the diuretic. That diuretic is creating a diabetic risk. That diabetic risk is not well understood by the patient. The patient's diabetes gets worse. They then go and see their second practitioner who manages their diabetes, who changes their insulin levels, and you end up in a cycle where the diuretic and the diabetic relationship becomes interlinked with each other. So concurrent use of multiple medicines may be deemed necessary and is often beneficial, but it needs to be managed and communicated. So the question that's raised there is, to what extent should we involve other professionals in a patient's care? So if you're concerned about the metabolic side effects, should you share that with the patient's primary care doctor, who's managing blood pressure or managing cholesterol or managing any other form of care like the diabetic care? And my question to you at this point is, do you keep a record of which medicines are prescribed by which caregiver? And when you provide care, do you effectively communicate with those other professionals around your changes in that patient's care? And if the answer is no, are you potentially contributing to a polypharmacy style of risk? You'll know the answer to that. And these questions are not to criticize the practice. They're rather there to help you look at areas where you might reduce the risk of an adverse outcome because of a patient safety incident. And it might not be your patient safety incident. It might be that the patient doesn't fully understand what's needed and hasn't fully disclosed because A, you may not have asked the right questions. B, they may not have considered the questions that you're asking. So later on, I'm going to talk about the physician's alphabet or the medical alphabet because it's largely illegible. But I use the incorrect use of medicine illustration that was there. And this comes from Preventing Medical Errors from the Institute of Medicine. It's from 2006, but these events are still happening today, where the physician writes an order for one medicine, the pharmacist fills the order for a second medicine. As a result of that, the patient enters into a treatment regime that's not appropriate, has a adverse outcome that can create the morbidity and mortality that we spoke about earlier. So self-evident on the screen are errors like this that are happening, and 1 in 24 patient safety issues, or 1 in 24 patient contact issues results in a patient safety issue that could result in a situation like this. Now, this could be you. This could have been you. And one of the things that we're trying to do as we go through this journey is to limit the adverse outcomes or the unfortunate outcomes or the poor outcomes with our best intentions, because this would be an example of what we spoke about very early in the presentation of the manifestation of a moral hazard. So if we pause now and we look at this and we say, what might constitute the incorrect use of medicine? The use of too many medicines per patient, the polypharmacy. The inappropriate use of antimicrobials, sometimes in inadequate dosages and sometimes in inadequate frequencies for non-bacterial infection. Now, I worked in an environment and there was a stage where vancomycin was the first line response. The question is, if vancomycin is the first line response, what would a second line response look like? So then the third thing is, and we spoke about this, the right use, the overuse of injections when oral formulations may be more appropriate. The failure to prescribe in accordance with clinical guidelines is a challenge because you may not be fully versed on what the clinical guidelines are. You may have your own therapeutic guidelines based on your experience, but those therapeutic guidelines need to be aligned to the clinical guidelines that we use as published by SAMA, as published by other bodies. So be aware of that and be mindful of the need to prescribe in accordance with clinical guidelines. There is also the unfortunate, inappropriate self-medication that's done, often using prescription-only medicines. So the patient, your patient, or the patient who's now your patient, through prescriptions from other practitioners, may not have used their medicine in the appropriate way. They may not have finished a antibiotic routine historically, and they may be using those medicines in a self-medication way without letting you know. There's also the risks of the interactions between alternative and modern medicines, and patients don't always consider that the over-the-counter medicines that they purchase, or the naturopathic formulations, or the homeopathic formulations, or other plant-based formulations that they purchase, would be considered to have a medicinal interactivity. St. John's wort is an example, arnica is an example. So bear in mind that when you're asking questions of your patients, you need to say what medicine are you taking. You may also need to say what allergy preparations are you taking, or what homeopathic preparations are you taking, to get a more complete or better rounded picture of what's going on in your patient's potential polypharmacy basket. So what would we then regard as a high-risk situation to be? High-risk situations are important because they're more often associated with significant harm. And significant harm can be due to unsafe medication practices or medication errors that lead to a potentially preventable complication and or adverse outcome. So three main contributing areas to a high-risk situation. The first are the use of high-risk or high-alert medicines. Those are often medicines with a low therapeutic index, but they have a low ratio of being their maximal tolerated dose with minimum curative or effective dose. So you need to understand which medications, high alert medications, high risk medications are being used, and are these medicines being used in the right manner to give you the right therapeutic index. The second are both yourself and your other colleagues and the patient's factors, over-prescribing and or under-prescribing and or misprescribing. So you may find that because of the lack of communication between yourself and your colleagues with your patient, or your patient's lack of understanding, you may be in a situation where the prescribing regime is disunited. And I'll share an example with you in another book that you may want to read. Back when I was doing some studies at the School of Public Health at Berkeley, we were doing a lot of work there with a health system called Kaiser Permanente. And the chairman or the chairperson at that point of Kaiser Permanente wrote a book called From Chaos to Care, describing the experience that he had with his elderly father and the treatment that his elderly father was getting from multiple healthcare providers. He recognized that because his father was unable to share his full treatment and health experience with each practitioner, that it resulted in there being a complexity in terms of which medicines were being prescribed, and the overlap of care led to sometimes absence of care or inappropriateness of care. And that would be your provider and patient factors. So the book is called From Chaos to Care. And then your third system in terms of a high-risk situation would be your system factors or your work environment. So whether you're using telehealth and telemedicine or not, what your patient load looks like, whether you're working in an outpatient department or in ward department in the hospitals. The COVID pandemic has significantly changed our work environment and has resulted in high-risk situations within these settings. So if your patient load is too great and you've got the risks because you're providing telehealth and not face-to-face care, or you've got anxiety in terms of how you're managing your waiting room, you may not be as attentive as you might be to the situation that that patient presents with. And that will then result in a high-risk situation, and that could then put you in a position where there's a medication error. So the third piece that I think is really important here, because we've spoken about polypharmacy, we've spoken about the inappropriate use of medicines, we've spoken about the high-risk situations. The transition of care is complex, because as we move between types of care and types of healthcare practitioners, we need better cohesion and better communication. So in order to have a formal structure to manage the transition points of care, and a transition or a transitional point of care would be between yourself and a second practitioner on a primary healthcare basis. It would be between yourself and the practitioners in an in-hospital basis and a post-discharge basis. So there are multiple transitions of care, and what you may want to look at in your practice is how many transitional points of care do you have in the care that you provide to the type of patients that you treat. Now, in order to manage that, there's 3 steps of recommendation that have come through. The first is, can you build your best possible medication history? And in doing that, you may want to have a form, and when you interview the patient, you want to then be able to say, how do we verify the information that the patient is giving us? And how do we record the medication history? You may want to have a self-declaration from the patient that is added to the declaration that they give you. And you may, if the patient is a child or an elderly person, you may want to verify that with a third party. The second thing you may want to do is, once you've got your BPMH, your best possible medication history, you then may want to create a medication list that you reconcile and update on a regular basis. So the medication history that you get from a patient that you've seen today may be significantly different in 30, 60, or 90 days, depending on the patient's experience. They may have gone to the pharmacy and bought an over-the-counter antihistamine. They may have gone to another practitioner and got a second treatment regime for a second morbidity or comorbidity. If that's the case, the next time you see them, you may be asking them, have you added anything to your medication regime, and write it down. And then the third thing about this is the communication and how you communicate with the patient around their medication list, around the medication history. So you would want to know two things. You would want to know from the patient if they've changed or added any medication or any preparation to their daily regime, and if they've seen any healthcare practitioners who's added additional medicines or preparations to their care. So it's a composite journey. It's part of your case history. It's part of your record keeping. It's part of your ethical obligations in terms of your registration as a practitioner. So you may be able to tick all of these boxes right now and say, yes, I keep a best possible medication history. Yes, I have a medication list for each patient. And yes, I communicate with the patient and I communicate with all other healthcare practitioners on these medicines, in which case you are running a world-class administrative practice. If not, you may say, what is my first incremental improvement in order to limit my exposure? So let's look at medication management, and let's look at not only these three steps on this slide, but let's look at safer medication management globally. So the first thing is, how do we look at safer prescribing? And here I refer you back to booklets 4, 5, and 9 of the Health Professions Council's Ethical Guidelines book. The first is, for each patient, you need to not only develop, but document a clear rationale for why you want to use the medicine or combinations that you want to use, given the risks, not only that the presenting complaint for that patient may present, but also what risks may the use of that medication or combination of medications present. You then need to record those risks. You need to record the benefits and your reasoning processes in your patient record. So to do this, you may want to have a pre-formatted patient record that prompts you to include all of your rationale. If you don't have that and you're still doing longhand narrative, you may want to consider migrating onto an electronic record format that requires you to fill in on a more diligent basis your diagnostic rationale and how you've done your risk benefit. The second piece to that is then, once you've got your diagnostic rationale, have you engaged with your patient? And you'll see there it says, in an informed discussion, consistent with the requirements of informed consent, about your recommendations and alternative options. Because it's the patient's choice, not your choice. The patient's choice what treatment they accept. It's your obligation to give the most appropriate treatment options. But in terms of informed consent, it's also your obligation to share the alternatives with the patient so that they are well informed. And those are the first two steps. Those are probably the less complicated steps. The more complicated step is to monitor the patient closely enough to ascertain whether there's side effects. Now, if there are side effects, you need to then be able to have monitored them close enough to intervene. And that may include lowering the dose or stopping the medicines or continuing over a period of time to see if the side effects begin to fade. Now, you would be unable to do that unless you have a disciplined system for monitoring that person post-consultation for when they are already taking the medicines. Now, we spoke earlier about your medicine applications list. Do you keep one? And if so, are you monitoring the patient in terms of that so that you can ascertain whether the medicines that you've prescribed that they've agreed to in the informed consent that you've held in your record, you see I'm moving up the 3 steps again, that you can see and you can note and you can feel confident that the treatment with the best possible outcomes that we could expect. So the World Health Organization talks about the 5 moments of medication safety. Earlier on in this presentation, I spoke to you about your checklist, and your checklist for your 5 moments of medication safety may have within each of these 5 components 2 or 3 questions. So what are your questions, or what are your rationale when you are going to start a patient on their medication? Now, that's important because when you start the medication, there are components of informed consent, as you saw on the previous slide. There's your diagnostic interpretations, there's your rationale, there's your risk management. Then there's the communication with your patient around how they take their medicines. And we spoke about the rights, the right patient, the right medicine, the right route, the right time, the right dosage. Now, in order to do that, your patient has to be educated on how they take their medicines. Then if you add a medication, what are the steps for adding a medication? You need to go back to informed consent. You have to consider the addition of that medication, not only to the side effects or contraindications with the other medications, but also in terms of changes to the patient's potential compliance behaviors. Then there's the question of reviewing the medication. And then ultimately, off the back of that, how do I stop, or how does my patient stop taking their medication? So each of those moments should form part of your checklist. So by example, when you're having your consultation with your patient and you consider starting a medicine, you need to consider what the starting of this medicine will do with their compliance as a patient and their access to that medicine, what the adding of that medicine will do to other medications already done, how you plan to review that medication, and ultimately when you're going to stop that medication, what that looks like. For example, you may give a regime for 4 days or 5 days or 10 days, and then what? Should the patient be calling you or contacting you or communicating with you? Should you be making a note in your file for you or one of your colleagues to be contacting them? So this methodology is put into place to try and create a daily, weekly practice awareness for your role in providing oversight and guidance for your patient's medication regimes. So there are some requirements, and this area on issuing prescriptions is in the HPCSA booklet 9, specifically section 7, and it says that a practitioner shall be permitted to use typewritten, computer-generated, or pre-typed or pre-printed standardized prescriptions for schedules 1 through 4. If you are issuing schedules 5 through 8, you need to issue handwritten prescriptions. Now, I say that because a lot of questions come up from practitioners to say, well, how can I issue prescriptions? So you can have a pre-printed form that you use, but you need to physically write out the medicine, the dosage, in terms of your schedules 5 through to 8. So be aware of that. You've got requirements. You're probably already doing this 100%. I'm just sharing this with you in the context of safe medication practices and good medication management. You need to make sure that your prescriptions and records are legible. One of the biggest challenges in defending a practitioner at a later date is your records may not be legible. And I use this as a slide, and I often joke about this, and I say, how did we end up being admitted into medical school as a student? And my joke was, well, you handwrote your application, and if they could read your writing, they threw you out. If they couldn't read your writing, you were welcome to join. So if you were to look at your scripts, are they clear? Are they legible? Could a third party read them reasonably and safely? Can they read your numbers? Can they read the dosage recommendations? Can they read the date? So if you were to go back and say, I am a reasonable practitioner, could somebody who wasn't me read this in a manner that was legible for them? So the final thing on the issue of medication management as it relates to patients is you need to, at the very least, in addition to all your record keeping for every patient that you do, again, this is in terms of booklet 9, specifically section 4 of the ethical guidelines, you need to have the proposed clinical management of the patient recorded. You need to have the medication and dosage prescribed. You need to record the patient's reaction to treatment or medication, including the adverse outcomes. You need to record any test results. But if I go back to section 4.18 that you can see there, how would you know the patient's reactions to treatment? And that's an open question. I'm asking that because if you're not following up with the patient the next day or 2 days after or 5 days after, you will not know whether that patient is getting an adverse effect because they may not phone you, they may not share that with you. So you have not only for your therapeutic obligations under booklets 1 and 2, and your obligations in terms of being a healthcare professional, but you also have obligations from a medication management point of view to follow up with that patient in a structured way. So bear in mind that as you go forward for safe medication practice, you need to document everything. You need to make sure that there is proper medication labeling. You need to make sure that your documentation is legible. And if you take nothing out of the slides, the medical alphabet is one of those that you should take. You need to make sure that you are recording the administration and the properly administered medicines. A lack of proper documentation for any medicine can result in an error. You need to make sure that there's reading of the prescription label and the expiration of the medicine if this is medicine that you're dispensing. You also need to encourage your patients to read the labels and check their expiration dates. There is a risk always, and you might not know this without follow-up, that you can have the correct medication with the incorrect label or vice versa. That can lead to a medication error because we are, in our best intentions, still human. There was a very good book written on efficacy of healthcare called To Err is Human. We do make mistakes, but we want to create a therapeutic environment where our mistakes are limited as far as possible. So there are 10 strategies for preventing medication errors that I'm going to share with you. There are many, but I'm sharing with you these 10. The first is ensure the 5 rights of medication administration. Follow proper medication reconciliation procedures. And that leads to the question of, do you have medication reconciliation procedures? Because you can't double or triple check procedures if you don't have them. So one of the outcomes that you may have after listening to today's presentation is to go and check your medication reconciliation procedures. Check them in terms of the 5 patient requirements, check them in terms of the 5 rights, check them in terms of the requirements in terms of the HPC guidelines. If you are working in a group, have the physician or another nurse read back your prescriptions. Consider name alerts where needed. This one I found is true, especially when you're sharing your information with another party. If you are doing 0.25 for your dosage, make it 0.25. So add a 0 in front of the decimal point. Importantly, as per the last slide, document everything. Ensure proper storage of medications. And that's not only proper storage for yourself, that's also proper storage for your patients to know for their medicines at home. If you're working in an institution, learn your institution's medication administration policies, regulations, and guidelines. And the final one, we used to have a Merck manual. When I graduated, I had a Merck manual. And in 1999, I bought the centenary edition of the Merck manual that had the Merck manual 1999 and the Merck manual 1899. At that stage, you would also get a MIMS drug guide. Nowadays, everything is digitized and you can get a digital guide, but you should have in your rooms a drug guide available where you can look at the medicines that the patient is taking. You can assess them against interactions, interactivities, doses, effects, and side effects, because one can't be expected to remember it all, but one should be expected to be able to have access to the most relevant information. And so I leave you with this slide, which is a complex, simple slide, which I call the medication errors risk universe. So the first thing to be aware of is there are situations that you need to be mindful of. Do you have high-risk situations that you work in? Do you check for polypharmacy? And do you look for transitions of care? In terms of the high-risk situations, are you looking specifically at inpatients? Are you looking at young children and the elderly because they can't always eloquently share with you what their risks are, what they're feeling? Have you made sure that there's not the administration of the wrong dose or the use of the wrong route or non-compliance with the treatment regime? Are you looking to see whether there's polypharmacy? Do you have a patient with 4 or more over-the-counter and prescription medicines and preparations? Have you considered the increased risk of side effects, the increased risk of drug interaction, and the complications of adherence when you've got multiple medicines? And then are you considering the impact as a patient moves between facilities, as they move between sectors of healthcare or between healthcare practitioners? Have you considered what the risk of communication errors are? With that, then, let's consider what the processes that you are doing for prescribing and or transcribing and dispensing are, and how you're educating your patient in terms of administering and monitoring practices. Also, if you're administering and monitoring, because that's your role, are you doing it effectively in terms of the best practices and guidelines? Equally, we then look at your principal causes. Do you have a weak or strong medication system? Have you considered what human error and fatigue or staff shortages may have in terms of your patient's experience? And have you considered what adverse drug events might look like? Are you looking at the 5 moments and the risks related to those 5 moments of care that we discussed, from introducing a medicine to stopping a medicine? Have you looked at a functional status, and are you encouraging adherence with the treatment regime? Are you empowering your patients with the adequate information and knowledge? And then finally, have you got a strategic framework for your patients and members of the public, in other words, their family and or caregivers? Have you got a strategic framework on how you manage medications in your practice? How do you engage with other healthcare professionals? And how do you manage the systems and practices of your medication? So this should give you a sense of 1 or 2 clear areas where you may be reviewing your medication practices within your private practice or within your institution in a manner that you can improve medication safety and minimize the potential for any patient safety issue that could lead to them failing to thrive or having an adverse outcome. At this point, I want to say thank you very much. I'm going to hand you back to Michael John to conclude today's session.
Thank you, Brad, for a most informative talk. As always, I'm sure that the practitioners who are listening in will find this to have been most engaging. For those of you, sorry guys, I'm going to have to stop the. Brad, we need to put the slide on with the medical errors if we can. Sorry, with the social media stuff. There we go. Okay, happy if I start again. Sure. All right. Thanks very much, Brad, for a most. Alrighty. Brad, thank you so much for a most engaging talk. As always, I'm sure that the practitioners are going to really enjoy what you had to address us on today. For everyone who's been listening in, and for anyone who perhaps wants to hear more about the CPD initiatives that Genoa Underwriting Managers is offering, please ensure that you take some time to follow us on the links that are appearing on your screen, either on LinkedIn or alternatively on our YouTube channel, Genoa Underwriting Managers. Thank you again for taking the time to listen in, and we welcome you at our next CPD series. Cool. Can you do the intro one more time? Sure. Brad, I'm just going to do the intro now. I was looking around apparently. So
okay.
To redo the start of this series of the talk.
Go for it.
Good day and welcome to another of the Genoa Underwriting Managers CPD series. My name is Michael John Demant and I'm one of the founders of the company. Genoa, as many of you will know, is a liability insurer with a long history in the professional indemnity space. We're not a typical insurer in that we don't insure your car or your house, and instead we are specifically focused on insuring professionals like yourselves. The Genoa team has been offering professional indemnity solutions for many years, and we are regarded as experts in this space. I have the pleasure today of introducing Dr. Byra, who will be focusing on medical errors. Over to you, Brad. Let's do one more just as a... All right, perfect. Sorry, I think I also looked at you when I... No, I'm going to bring it a little bit down. 100%? Yes, I can. Good day and welcome to another of the Genoa Underwriting Managers CPD series. I am Michael John Demant and I'm one of the founders of the company. Genoa, as many of you in the room will know, has a long history in the professional indemnity space. We're not a typical insurer in that we don't insure your car or your house, and instead we are specifically... Want me to start again? No worries. Tell me when you're ready and I'll go.
You know what I think's happening? When you're reading, I was just looking now, because it's so wide, you're going left to right. And if I do that, you still see that.
Yes, I can. No problem.
You okay with that?
Yeah.
Okay, let's try that. Stand by and go.
Good day and welcome to another of the Genoa Underwriting Managers CPD series. My name is Michael John Demant and I'm one of the founders of Genoa. As many of you may know, Genoa is a liability-focused insurer with a long history in the professional indemnity space. We're not a typical insurer in that we don't insure you... Sorry, I'm going to have to start again. I apologize.
No problem.
Okay. Just... Okay, let me get a bit closer and then I can see. Sorry, my eyes are poor. All right, tell me when I can
Not
go.
without its challenges, hey?
My eyes are so bad, Brad. I'm battling to... Okay, let me know when I can go.
Stand by and you can go to the...
Good day and welcome to another of the Genoa Underwriting Managers CPD series. I'm Michael John Demant and I was one of the founders of the company. Genoa, as many of you will know, is a liability insurer with a long history in the professional indemnity space. We're not a typical insurer in that we don't insure your car or your house, and instead we are specifically focused on insuring professionals like yourselves. The Genoa team has been offering professional indemnity solutions for many years, and we are regarded as experts in this space. I have the pleasure of introducing Dr. Byra, who will be focusing on medication errors. Over to you, Brad.
Cool. Happy with that. Thank you.
Fine? All right. Sorry about that.
Yeah, no problem. Guys, okay, so I'm going to end this one